All right, great. So this might take just a minute, but the connection may be a little bit delayed as I'm scrolling through this, but let's give it a try. All right, so we're going to talk about junctional rhythms. And when we're talking about junctional rhythms, those are rhythms that originate, they start in the junction at the AV node. So normally electricity would travel, as you know, down from the SA node, go through the atria, and then eventually make its way to the AV node, which would work as a gatekeeper before sending that signal forward into the ventricles. And so in this case, what we have is the SA node isn't originating the beat. The secondary pacemaker functions of our AV node have taken over. And that may be for a variety of reasons. Often, though, this is not generally going to be by itself a rhythm that will likely produce a cardiac emergency independently. It may be associated with other things like H's and T's, or something like an AMI as an origination. So the rhythm itself likely is not producing a whole lot of problems, but it can in certain circumstances. So let's review a couple concepts for junctional rhythms. All right, let's get started by reviewing just the basic concept of the morphology of the P wave that's present in a junctional beat. So generally there's three different ways that the P wave can present itself in a junctional beat. Generally though, the QRS is going to be mostly narrow because it's still originating above the ventricles. So what are the three ways that we might see, or three morphologies of the P wave that might be present in a junctional beat? Go ahead and try to think about that, answer it, and then we'll draw an answer here in just a second. Pause the video if you need longer. Okay, so welcome back. So if we're answering this question, we'll want to just first preface this by saying, if we're looking at lead 2, we would expect that a normal sinus rhythm would have a P wave that's originating upright before our QRS. So there's a few variations of that would present a junctional beat. Now the junctional beat should have still a pretty narrow QRS because this is originating above the ventricles. So the speed it takes to go through and originating at our pacemaker is still going to be pretty quick. So the first presentation might be that there's an absent P wave. The P wave's not present. It could be buried within the QRS, happening simultaneously, where we wouldn't see it because the mass of the ventricles is producing way more electricity than the junction that's creating this P wave. Or we can have a P wave that presents inverted. And so if the P wave is upside down, one variation in a junctional beat might be that the P wave is upside down preceding the QRS, almost as if it's in the same position it should be, but it's inverted. And then another version, the final morphology, could be that we have our QRS and the P wave right here follows or is kind of tagging on to the QRS, in which the P wave has happened after the QRS. So those are our three major morphologies associated with the P wave in junctional beats. And again, it's originating in the junction around the AV node. And so electricity in the P wave is going through the atria. Here it's happening to go through the atria at the same time it goes down, so there's no pause for the atrial kick, or it's happening right afterwards, retrograde, firing upward into the atria instead of moving from the top down as we'd expect with the SA node. All right, let's review another concept. So another question for us is, how will a junctional beat impact cardiac output? So consider this. Now remember, the junctional beat, it's originating at the junction. So if we have atrial depolarization, it will likely be retrograde or occur at the same time as the ventricle is squeezing. So consider what that does to our cardiac output, and ultimately, maybe, not always, in some cases, blood pressure. Well, let me make a little bit of room, so pause again if you need to. But our normal formula would be cardiac output equals heart rate times stroke volume. Now, certainly the heart rate may be impacted by junctional beats because junctional beats may be a variety of heartbeats, including bradycardic heartbeats. So that would increase cardiac output. As the heart rate goes down, it tends to bring down our cardiac output. But in general, because of that abnormal P wave, that retrograde P wave, or the P wave occurring before or during the QRS, in which there's really no atrial kick, we can have a decrease in the patient's stroke volume. And so the decrease in stroke volume may or may not be also associated with the decrease in heart rate. And so that can decrease cardiac output. But again, that's usually pretty rare when we have the presence of junctional beats. But that would be what would tend to happen. Now, another important component of junctional beats is then classifying junctional beats. And we classify junctional beats in a primary set of ways using essentially the heart rate. So remember, this is coming from the AV node. So always remember that as a pacemaker, the secondary pacemaker, the AV node is going to produce, our secondary pacemaker, a rate of depolarizations between 40 and 60 beats per minute. So that's slower than our normal. That would be what we'd expect for a normal function if the AV node is taking over in the absence of the sinus node, starting the depolarization for the heart. So the first one to look at is a junctional escape beat or junctional escape rhythm. So junctional escape beats generally happen a little bit differently than, say, something like a PJC. So a PJC would be a premature junctional complex, and the hallmark of this is that it occurs before the beat that would have been there occurred. So it's premature. It happens before the next beat would have landed. With the junctional escape rhythm, what we're seeing here is usually a sinus rhythm in which the SA node doesn't fire, so there's a pause from the last sinus beat, and the junctional escape rhythm is the AV node taking over. And so after the pause, so not premature, after the pause, instead of having a return to the sinus rhythm, we now have a junctional rhythm. And it could be a single beat, but it could continue into multiple beats. Now, if we're talking about a junctional escape rhythm, junctional escape beat, this would generally be the AV node kind of taking over its secondary pacemaker. So we'd expect its rate to be between 40 and 60 beats per minute. Accelerated junctional is going to be a little bit faster rate, so you get the idea, accelerated. But notice, it's not junctional tachycardia. So it's going to be a beat per minute range between junctional escape rhythms, 40 to 60 beats per minute, and tachycardia. And in the adult, we would classify tachycardia as greater than 100 beats per minute. So accelerated junctional is going to be a junctional rhythm, so it has the parameters of those P wave changes, but still probably a very narrow QRS, of a beat range between 61 and essentially 100 beats per minute. So it's accelerated, but still not fast enough to be tachycardia. And junctional tachycardia will be beats that are above 100 beats per minute. Excellent. So the major classification of junctional beats is actually pretty straightforward. All right, let's go ahead and start by interpreting a few ECGs that are all going to be junctional rhythms, but they won't necessarily be in the order that we've described there to challenge us a little bit. Okay, so let's go ahead and get started with this first rhythm, 8-5. So this rhythm here, let's go ahead and start. I like to start with counting our rate to determine how fast or slow this is. And so we'll use the 6-second method here for this. Although it's regular, we could probably use the sequence method. I'm going to count 1, 2, 3, 4, 5, 6, 7, 8.5, I would call it. So that would be about a rate of 85 beats per minute. Okay, so that generally seems to be a decent rate, but we have to figure out a little bit more information before we can give it a name just yet. All right, now let's go ahead and look at our P waves and determine whether or not we have P waves before every QRS. And so we got a P wave here, P wave here, P wave here, and then we got a change. So let's highlight that. But we do have a P wave. So there's a P wave with every QRS. Our R to R interval looks to be about even. So this looks like a regular rate. And our PR interval, let's go ahead and start with one of these beats here. Looks like our PR interval is going to be from here to here. So that looks like to me about 0.12 or so for our PR interval. So that looks good. But let's also take a look at one of these rhythms that has the inverted P wave right here, because it is technically a little bit different rhythm. And so that looks to me to be about looks like 0.08, right? So 0.08 on this one, and this one's a little bit wider, so I think 0.12. Okay, and again, do that because we have a different rhythm, so we need to kind of look at these as well. Also, let's look at our QRS. So we'll look at a rhythm with an upright P wave. Looks like our Q wave, S wave. So that looks like we've got about 0.06 for our QRS. And then let's look at this QRS. That's a little wider, so it looks like it might be 0.08. Okay, excuse my chicken scratch here. All right, let's keep going. So we have a P wave, we got a PRI, we got our QRS. It does look as though we might have, let's see where our J point would be. Sorry. So electric line is here. J point would be here. So it looks like we might be just a little bit under 1 millimeter if we've got some depression here. Okay, looking at our others, looks about isoelectric once we get back to this other one. So it may not really be, it might just be a little bit of a delay. Okay, great. Now let's go ahead and try and figure out, do we have any ectopic beats present here? And I don't actually see any ectopic beats, but I do see that we have a change. So it looks like we're starting off with something that, if we look at this rate, this is going to be around, if we use the sequence method, this is going to be a normal sinus rhythm. And it looks like the rate's going to be for this, so 300, 150, 175, this is going to be about 75 beats per minute. So that would be a normal sinus rhythm. That's going to be present all the way until we get to right here. And once we get to that point, we now have a new rhythm. So if we're looking at this rhythm, let's go ahead and find a representative rhythm that's about on point. So that one looks there, so 300, 150, 175. So yeah, this is going to be around 75, 80 for this range. So this would qualify as a junctional beat. It's faster than 40 to 60 beats per minute. So it's not going to be a escape beat, junctional escape beat. So instead, it looks like we have normal sinus rhythm that turns into a accelerated junctional beat. Great. All right, so normal sinus rhythm looks like it's turning into an accelerated junctional beat. All right, great. Okay, let's go through this rhythm as well. So this is 8-7, it looks like. So in this rhythm, we'll go ahead and try and identify our underlying rate. So our 6-second method, we've got 1, 2, 3, 4, 5, 6. So it looks like we're around 60 to 65 beats per minute with our least precise method. So this may qualify, it's very close, but it looks like it's probably not going to be a rate that's bradycardic. So if this is going to have junctional components, we're probably going to be in the accelerated junctional range. But again, let's take a look. So let me see, do we have P waves for every QRS? And we do, but they are inverted. Our PR interval here looks like, let's pick this one here, starting there, ending about there. So that's about 0.12 or so on our PR interval. So probably 0.1, I'm guessing, is a little bit more accurate. Our PR interval. Our QRS, starting here, ending here, looks like 0.08. Okay, so good, still pretty narrow. Our P wave is inverted, and it looks like, excuse me, we might also have, our isoelectric line would be here. We're very close to about 1 millimeter. We're very close to about 1 millimeter here of potential elevation. And this looks like an inverted T wave. Okay, so that may be telling us a little bit. Again, this is lead 2. So we're going to probably need to clean this up diagnostic using a 12 lead. But from what I can see so far, we may be concerning ourselves about some injury or ischemia, maybe even infarct if we've got inverted T wave. But again, we need a 12 lead to check that out. Okay, so something that we are concerned about, so maybe a little bit of elevation, inverted T wave. Now let's go ahead and start classifying this. So if we're looking at this rhythm and we've got a rate of, what do we say, 60 to 65 beats per minute, certainly 60 is above the range of 40 to 60, 40 to 59 or so would be our AV node working. So that would mean that this is an accelerated junctional. Okay, good. Hopefully you're seeing that as well. All right, let's move on to the next one. What do we have here? All right, we'll start with 812. Okay, so now on diagram 812, let's take a look at this one. Okay, all right, so let's go ahead and get our rates. So I'm just using 6-second. Looks like our rate's going to be about 80, but we do have a change in the R to R here that you can see visually. So this looks like it still continues regular after this change. And so we'll identify that a little bit more in just a minute. So rate of about 80 beats per minute. Let's check our P wave. So do we have a P wave for every QRS? So we have a P wave here. It's upright, looks normal. No P wave. Okay. Inverted P wave. P wave, inverted, 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 inverted. So it looks like we have one rhythm here. We have a beat here, and then another rhythm that continues on. So we have really three different types of beats that are presenting in this process. So I would probably want to get a little bit longer strip here if I wanted to determine what this first rhythm is. So we'll just call that number one, this beat here, number two, and then number three is all the rest of this. I might want a little bit longer strip to determine if I could capture what that was, or if it's just changing back and forth to determine it. But what we have present so far, let's take a look at. So let's start here. We'll look at beat number one. Beat number one has an upright P wave. The PR interval here looks actually a bit wide, so maybe we're looking at 0.12 to 0.16 in our PR interval, although still, I would say, within normal limits, but a little bit wider than what we've seen so far. Our QRS is very narrow, so it looks like 0.06 to 0.08 on my QRS, so narrow, good. I don't see any changes in the ST area, and my T wave is upright and appropriate. Okay, so that looks like it's a sinus beat. Maybe there was a sinus rhythm before, but I only have this one beat to tell me. And then we have this next beat, no P wave. It looks like it would be early, just a guess. I don't have the other beat to look at, but if it continues down this beat that we see in this direction, this looks early. So I think this is premature, and it appears to have, excuse me, it appears to have, maybe there's a little bit of a P wave in here. It's very, very narrow. So I actually think this is going to be a PAC. So we've got a PAC, and then we go into an inverted P wave, narrow QRS. Our PR interval here is 0.12. Good. Our QRS looks about the same, 0.06 for our QRS. And then we continue regularly down that. So this looks like we started at, I'm assuming, making an assumption here, maybe normal sinus rhythm. I think we've got a premature atrial complex here. And then we've got, following through, we have with our rate here, an accelerated junctional beat because of the rate of 80 beats per minute. All right, so normal sinus with one PAC, looks like it's a second complex, and then we're carrying through the rest is going to be an accelerated junctional. I don't see anything abnormal otherwise. All right, let's take a look at another ECG. All right, again, these will all have a junctional component. So this is going to be 8-4, diagram 8-4. Looks like we have, if we count our rate, I would say this counts 1, 2, 3, 4, 5. So this is actually pretty slow. So it's going to be more than 50, but it's going to be probably less than 60. So why don't we call it 55, 56 or so beats per minute, which is a bit slow. So this may be that, depending on what we have going on, this may be that this has a component to it that's a little bit slower than what we've looked at so far. Let's look at our P waves. Do we have a P wave for every QRS? Looks like P wave here, P wave here, P wave here. Got a bit of a pause, no P wave, P wave, P wave, okay. The PR interval, let's look at this complex here. The PR interval here is, it's not that wide, it's going to be to about that point. Okay, so that looks like 0.16. Good. QRS, or our QRS complex is going to be from here to there. So that looks like it's about 0.12, 0.1 for our QRS. Let's see, there's the isoelectric line, so I'm not convinced that would look like depression to me. Otherwise, I think it looks pretty good. Let's see, we now have another P wave, looks like about the same beat. T wave, P wave, okay, R to R looks about right. And then we've got this long pause. So my beats are about that wide, right? So the next one would probably land about here. So this looks like this is delayed, right? And then we go into a beat that has no P wave. QRS is still pretty narrow, but looks a slightly bit different. And then the T wave is a little more pronounced. So morphologically, this is a different beat after the pause. And then it looks like we got our P waves back. So this looks like we have, with this rate, we have a sinus rhythm. So this would be sinus brady. Now, if you were looking at this complex here and thinking that maybe that complex was a PJC, remember, it's not premature. It's actually happening after it should have. This is a elongated pause, so a little bit longer pause than we would expect. And so this is actually going to be a junctional escape. Again, we've got our rate less than 60. The AV node was, the SA node rather, was working with these first complexes. And then, so SA node, right, sinus. And then we have a pause where the AV node was waiting to get the SA node signal and it didn't come. So this is the AV node taking over. This is the AV node making a secondary pacemaker. So this is one beat. So it's going to be a junctional escape complex, junctional escape beat. Excellent. All right, let's take a look at another one. I think I got two more. So this is 8-19. So if we look at this, let's count our rate. So this is probably going to be a half. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So this looks like a pretty fast rate. So I think this is probably, since we got a half, we've got 125 beats per minute. So that's technically tachycardia. All right, let's check. Do we have a P wave before every complex? And it does look like we've got inverted P waves here. So inverted P waves, they look to continue all the way through. This looks pretty regular. R to R looks like it's marching out. Let's see, my isoelectric line is going to be somewhere in this range. So yeah, I don't think we have much in the way of elevation here. Our PR interval is going to be 0.08 and our QRS complex 0.1. Okay, so that's within parameters, just about. We're fast, so the T wave is getting close to our inverted P wave, otherwise that looks okay. All right, great. So this is going to be a faster than normal beat. We have our inverted P wave, so this is going to be junctional. And the rate is telling us, because it's tachycardia, this is junctional tachycardia. All right, excellent. And I think I've got one more. Okay, let's take a look at this one. I don't think we've looked at this one yet either. Okay, let's start with our rate. So this is going to be 1, 2, 3, 4, 5, 6. Okay, so this is about 60 beats per minute. Yeah, I don't think this qualifies. So yeah, 60 beats per minute. Okay, we have a P wave. So good, good, good. Looks the same. Okay, we got a change here, and the next one doesn't look the same. P wave, P wave, P wave. Okay, good. Our PR interval is a little longer than it is. Okay, so that looks like we've got 0.12 on our PR interval. Our QRS looks like we're at 0.1 or so. Let's see. I'm not sure it'll qualify with our J point. I don't really feel like that's going to qualify as depression. Okay, so it looks like we have both, aside from this one beat here, we have an underlying rhythm, 60 beats per minute. It's sinus in origin, meets all our parameters. So this looks like a normal sinus rhythm underlying. And this one unusual beat has an inverted P wave, still pretty narrow, and it's happening earlier, just a little bit, but it's happening earlier than it would. So this would qualify as the premature junctional complex, or PJC. All right, so normal sinus rhythm with the PJC present. All right, excellent. Okay. And did we do this already? Oh, we've already done this one. So this is, we did earlier. Okay, great. So to wrap up, let's talk a little bit about when you're managing patients that have junctional rhythms, what are we going to do for treatment? Like, what is our treatment algorithm? So generally, the way that we will treat this is to remember that it may not actually be an issue. It could still be generating good cardiac output, depending on other mechanisms. It may be because of other causes. And so it may be that something else is causing this rhythm. And if we're called for 911, we're responding to a call, they've got signs and symptoms, those signs and symptoms may not actually be coming from this beat. Now, if they were coming from this beat, then it might be that the person's had a heart attack and it's kind of knocked out some of the electrical pathway, or the SA node is impacted. So that could be one thing. So we want to use our ACS algorithm. Another consideration might be that the patient has a slow rate. So if a junctional rate is slow, like a junctional escape beat, where we'll have rates that are below 60 beats per minute, that could be bradycardia. So they may be symptomatic, they may be unstable. So symptomatic or unstable bradycardia might be the pathway that we have to use for that. But again, it might not actually be the cause. So remember here, H's and T's will probably find our reversible cause for the underlying rhythm. But if it's slow enough, it may qualify for bradycardia. If it has other symptoms that are associated with an MI, then we would likely consider the ACS algorithm. Okay, so that's all I really have for junctional rhythms on this video. So hopefully this is helpful for you. If you have any questions, please reach out to me. And as you're watching this for the paramedic class, these are only a couple of the Huffbook measurements that you'll be making. So do your best to go through, measure the different beats. So if we have a beat that has a different morphology, we have to measure that again. So we can't use that as a representative beat for all the different beats. So we'll have to measure those different beats, QRSs, PR interval, evaluate for changes in T waves and so on. Because if it originates in a different area, we could have changes in any one of those other areas down the line. So we want to compare all of the different beats that are present. And we saw some here where we had 3 different beats: a starting beat, a transition beat, sometimes a single beat, and then a beat that followed that transition. So all of those need to be evaluated, measured, rates counted to give us an accurate picture. All right, stay safe, everybody. We'll talk to you soon. Bye.